All right, let's get right into it. If you are prepping for the NCLEX, you know pharmacology safety is a huge deal. Today, we are taking a deep dive into one of the most high-risk, heavily tested drug classes out there, antiepileptics. My goal is to get you so ready you can tackle these questions with total confidence.
So to really get a handle on these drugs, you first have to picture the problem. Imagine a wild, uncontrolled electrical storm just raging through the brain's neurons. That's a seizure. It is pure chaos. And our entire job is to stop that storm. And that's exactly where anti-epileptic drugs, or AEDs, come into play. They're designed to quiet down that chaotic firing and bring back some order. But, and this is the critical part, in stopping one danger, they create a bunch of new ones. As nurses, we are the safety gatekeepers, and that role is exactly what the NCLEX is going to test you on. Okay, so here's our game plan. We're going to start with the big picture rules for the whole class, then we'll break down the classic drugs, the broad spectrum ones, and a few niche players you need to know. And we'll wrap it all up with a rapid-fire review to make sure the stuff is locked in for exam day. So, first things first, Section 1, the big picture. Before we get into the nitty-gritty of phenytoin or carbamazepine, you have to know the fundamental rules that apply to all of them. Think of these as the universal safety principles. Now look at that core idea at the bottom. This right here is a classic NCLEX trap. AEDs do not, I repeat, do not cure epilepsy. They only prevent seizures. This means patient adherence is absolutely everything. Missing even one dose can tank their seizure threshold and trigger the exact electrical storm we are trying so hard to prevent. And here they are, our cast of characters for today. These are the heavy hitters, the high-yield drugs you are most likely to see on your exam. We've got drugs for specific seizure types, like tonic-clonic, the classic convulsions, and focal seizures, which just affect one part of the brain. Plus, we've got the broad-spectrum agents that cover a bunch of different types. We're going to break down the must-know safety facts for every single one. Okay, let's get into our first group, the classic AEDs. We're talking phenytoin and carbamazepine. Now, these are some of the older drugs, which means the NCLEX has had plenty of time to come up with tricky questions about their very specific and very dangerous side effects.
First up, phenytoin, also known as Dilantin. You have to know its therapeutic level. It's 10 to 20. Got it? 10 to 20. Anything over 20 is toxic territory. Now, the number one expected side effect, the one you'll see all the time on exams, is gingival hyperplasia. That's this massive gum overgrowth. So your teaching has to focus on meticulous oral hygiene. But the most dangerous risk? That's the life-threatening skin reaction, Stevens-Johnson syndrome. For the NCLEX, any new rash on this drug is a massive, screaming red flag.
Okay, let's switch gears to carbamazepine, or Tegretol. If you remember one single thing about this drug for your test, please let it be this word, agranulocytosis. This is a catastrophic drop in white blood cells. It basically wipes out the patient's immune system, leaving them wide open to infection. It is a true medical emergency. So, let's apply that. Picture this scenario. A patient on carbamazepine calls you. They've got a new sore throat and a fever. What do you tell them? You have to recognize these aren't just minor cold symptoms. These are the classic warning signs of agranulocytosis. Your priority is to tell them to get to a clinic or an ER immediately for a blood test. That's clinical judgment, recognizing the cues and acting fast.
All right, moving on to Section 3, the broad spectrum agents. These drugs, like valproic acid and levetiracetam, are powerful because they cover a wider range of seizure types. But of course, they come with their own unique and very testable dangers. With valproic acid, or Defactote, there are 3 deadly risks you have to burn into your brain. First, hepatotoxicity, liver damage. That means we have to be monitoring their liver function tests and teaching them to report any signs like jaundice. Second, pancreatitis. Any report of severe abdominal pain is a huge red flag. And third, it is highly teratogenic. It is incredibly dangerous in pregnancy and can cause devastating birth defects.
Now, let's talk about levetiracetam, better known as Keppra. You're going to see this one a lot in clinicals, and this slide really shows you why. Compared to the old school drugs, it has way fewer drug interactions, you don't need to do routine lab monitoring, and it's generally a lot easier on the body's organs. But you knew there was a but coming, right? And here it is. This is the hidden danger.
and it's a favorite NCLEX topic. While Keppra might spare the liver and the blood cells, it can really mess with the mind. We're talking about new or worsening irritability, depression, even serious aggression. Some people actually call it Keppra rage. The nursing priority here is to assess the patient's mood and teach the family to report any of these personality changes right away. Okay, let's hit section 4. Think of these as the drugs you absolutely cannot afford to miss. They're often tied to one very specific, very deadly risk, or have a super narrow use, which just makes them perfect for exam questions.
When you see the drug lamotrigine, or Lamictal, on the NCLEX, I want your brain to immediately scream rash. Just like phenytoin, this drug carries a significant risk of causing Stevens-Johnson syndrome. The key rule for the NCLEX is simple. A patient on lamotrigine who develops any kind of new rash needs to stop that drug and call their provider immediately. No exceptions. This table gives us a quick and 30 rundown of a few others you should know. Ethosuximide, that's for absent seizures, those little staring spells, and that's pretty much it. A silly way to remember it is that ethosuximide sucks the staring spells right out. For phenobarbital, an old-school barbiturate, the number one thing to worry about is respiratory depression. And gabapentin, while it is an AED, you're almost always going to see it used for neuropathic pain these days.
And that brings us to our final and maybe most important section, the NCLEX Rapid Review. This is where we pull everything together, focusing on the universal rules and the common traps to make sure you are 100% ready for test day. These are the 3 warnings that apply to the entire drug class. You've got to know these cold. First, all AEDs carry a black box warning for an increased risk of suicidal thoughts. You must assess your patient's mood. Second, you never stop these drugs abruptly. That can trigger status epilepticus, a life-threatening emergency. They must be tapered. And third, many are incredibly dangerous in pregnancy, which means patient counseling is absolutely critical.
So let's walk through this just like you would on the NCLEX. The scenario, patient on lamotrigine calls with a new rash and fever. Step 1, recognize the cues. You immediately connect that drug to that symptom and your brain says high risk for SJS. Step 2, prioritize. You know this isn't just a mild side effect, it's a potential killer. So step 3, act. Your priority action is to tell them to hold that medication and call their doctor right now. That's the framework. And this slide right here basically gives you the answers to the test. These are the traps you need to avoid. Never, ever treat a new AED rash as mild. Never ignore a fever or sore throat with carbamazepine. Always teach about the dangers of stopping suddenly. And always, always assess for those mood changes, especially with levetiracetam. Avoiding these common mistakes is how you pass.
So if you're going to remember one single sentence from this entire review, let it be this one. Antiepileptics, they control seizures. That's their job. But it's our monitoring of labs, our vigilance for rashes, and our relentless teaching about adherence that ultimately decides patient safety.
And I'll leave you with one last question to get your brain working. In a patient taking an AED, which of these is the most acutely dangerous finding? Gum overgrowth, aggression, or a new rash? Think about it. Which one represents the most immediate threat to your patient's life? That's the kind of critical thinking and prioritization you need for the NCLEX. You've got this.